All, this is Dr. Mobeen Sayed from DrBeen.com. Welcome to one more show. Today we will talk about the questions that you have, and most of those questions are on Twitter. If you wanted to follow me on Twitter, the Twitter handle is right here at DrBeen_medical. So we're going to go over the Twitter questions. We would also go over the questions that are here in the live stream as well as usual. So let us start. The very first thing that I want to do is, after welcoming you, is to actually, so this is DrBeen.com. This is the Twitter link itself. And the first thing that I would like to do is to actually talk about the cool beans. So starting from the father of the doctor that I said yesterday that I was worried about, he is fine. He is actually doing much better. So thank God. So here is what his report came in. Father is feeling much better. His vitals are for today pulse 84. That is a good news because that means heart rate is within normal ranges now and it is not stressed out and it's not trying to take care of the body. Respiratory rate is 23 per minute, which is also going back towards normal. His respiratory rate had gone up to 28 and more, which was a sign of stress on the body, the infection and less oxygen. Blood pressure 110/70, that is normal. Blood sugar came back to normal. Oxygenation at rest at room temperature is now 93%. Now remember that he was experiencing oxygenation drop of up to 86 or 80 at room temperature if he would stand up and walk about. So from there at room temperature 93%, and with 2 liter oxygen inhalation 96%. He is not feeling bad anymore. He's not irritated anymore. He looked fresh. He is gossiping and smiling and talking, and his voice is much more energetic as well. So that is a great news for someone who is 70 years of age, who had ischemic heart disease, has diabetes, has COVID-19, had widespread crept in his lungs, and was continuously going downwards instead of actually improving. So his C-reactive protein was going up, his D-dimers were going up, his ferritin was going up, his liver enzymes are going up, his creatinine profile, the renal profile was showing continuous deterioration. From there, since the ivermectin has started, he has started bouncing back and he is almost recovered. So that is one good news. So thank you very much for everyone who has prayed as well. I had been requesting for him because I was quite worried. His oxygen saturation was dropping a lot. And I received that patient a little late. And now just some medical thinking here. I think that one issue with the management was that he was started on dexamethasone right from the very first day. So starting someone on dexamethasone or steroids from the very first day causes the immune system to be suppressed and allows the virus to just roam around, cause destruction, and then replicate and increase in number freely. So I feel that we should not start steroids right in the beginning because that might actually keep the immune system in check, but would also allow the virus to spread. So in this particular case, I thought that the reason that the patient became much more stressed out was that he was receiving steroids while he had virus as well. And so then when the ivermectin was given, that came in and helped by reducing the virus, and that is how the patient started recovering. The second news about the same family, his wife, this doctor's mother, she has developed COVID as well for last 4 days now. She is relatively asymptomatic. Today he sent me a message that she may have some crepitations in her lung, but generally she's fine and she started on ivermectin. He asked me to start her on steroids and I said not yet. So now it is 3 or 4 days. I'm going to observe for 1 more day with her clinical profile, and then I would decide if we should start her on steroids or not. So that is 2. Then the other cool bean, he is the doctor from Greece. Remember I talked about it. He is actually head of the COVID unit in one of the wards, and that is, he himself has gotten it. He is in quarantine. The interesting thing is, I was talking with him today. Interesting thing is, let me just pull it up 1 second, that he has tested his antibodies now on day 4, 7, 11, and 13, and he has no antibodies. And he has relatively milder symptoms. So I responded to him and I said, looks like your innate arm and your cytotoxic arm took care of the virus. In addition to that, so he responded and he said, my vitamin D level are 100 nanogram per milliliter and my white blood count is normal. So it is possible that his humoral arm that produces the antibodies is not kicked in that well, and it is the innate arm and the cytotoxic arm that became more active, just like it happens in children or some folks, and it looks like they have become less symptomatic. His mother also got COVID, and she also managed it without much symptoms. And today he said that his father has developed COVID as well. And he said, so his father's history is interesting. His father is 81-year-old. He has fever now for last 10 days. He's not moving about much. He has neuromuscular issues. His fever is totally off from moving and slightly disoriented, but with fever. So he has, this doctor has been giving Zelenko protocol to his father, but he continued to deteriorate. So he said that now, since yesterday, I have started ivermectin as well. The reason he did not start ivermectin before was that he was apprehensive. The doctor was apprehensive that his father has dementia, plus his father had a stroke about 34 years ago. So he then asked me, he said, do you think that his blood-brain barrier is intact? So of course, without actually doing scans and those things, I cannot speculate, but I just used some clinical thought and I discussed it with him to say, if somebody's blood-brain barrier is actually compromised, then our external things in our blood and the immune system would just continuously pour into the brain and would just continuously cause so many problems. So if he is generally okay, dementia is a brain internal problem, not an outside issue. So I said that his BBB should be okay and ivermectin should be all right. So he has started him on ivermectin. One more thing that he shared with me, he said that in his ward, there were 100 patients that he has treated so far for COVID-19. Out of them, 6 have died, unfortunately. And the vitamin D levels are very interesting. Those who passed away, their vitamin D levels were lesser than 7. And for everyone else, the vitamin D levels were 25 and above. So 75% of them had less than 15, and then 25% had more than 25. So there is a correlation with vitamin D. So that is the second cool bean. And the third cool bean that I have been talking about, 58 years, he's waiting for his RT-PCR. Remember, he developed COVID-19. He became all right after he started ivermectin. He was taking prophylaxis that I had been talking about for some months now. And so it was an easy thing for him, almost mildly symptomatic. And now he's going to get another RT-PCR because his previous RT-PCR a few days ago came back as presumptive positive. He's waiting for the new results. So of course, his question was, why do I still have the virus? So I said, let's wait for the third RT-PCR and then we'll talk about it. The other thing he asked about was, should I change my mother's prophylaxis from hydroxychloroquine to ivermectin? And I said that, yeah, that should be fine. So these are the updates. Once again, somebody had asked that if I have any issue with the hand. No, this is just my glove that I wear and draw. So when I draw on the screen with this, it allows me to move my hand more freely. Plus, it causes palm rejection. So the static from my hand does not go to the touch screen. Okay, so this is what we have. Let us start our discussion. So I'm going to start with the Twitter questions, and then I'm going to come over here for the live talk as well. So let me ask this actually. How is everyone here in the live talk? So Margaret McInnes, good evening. How are you doing? DDS, hello. Claire, hello. Good evening, Jamie. Good evening. Today is my favorite day. Today is our day. We can talk and do whatever we want. Good morning, Vasant. Anthony, FAQ Fridays. Cheers in Boston. Cheers. My son just moved to Boston, Anthony. Kelly, hi. Margaret, good evening to all. Cool Beans as well, definitely. Hello, Dr. Bean, Luffy and Cool Beans family. Hello. Luffy was just here, I think, providing me with his instructions to do good, and he has just gone. Hello from Ireland. Welcome, Doc and everyone. I believe you are from Japan. Welcome. I've seen some of your comments. A very good, Sir Bean and all Cool Beans. Kohima, India. Welcome. Welcome. So there's the very first question from Mohammed. What is the relation between long haulers and carrier individuals of familial Mediterranean fever plus mutated MEFV? I want to keep my discussion towards COVID-19. Please send me this question separately and we can talk about it, or send it to me in an email. So great news on our Cool Beans. I am seeing that again, thanks to the lucky stars, to the universe, to God, to Allah, to whatever you believe in. And me saying this has already made me target of many of the religious folks as well, who just keep sending me messages that why do I do this? We have all kind of folks in Cool Beans. And the point here is not to sit down and have debates. The point here is to learn together to protect ourselves. So I am not going to indulge into these things. This is why I kind of talk about all of the belief systems. So, so let's start our discussion before I get lost in pleasantries. So I'm going to share my screen and we are going to look at the Twitter. So here is that Twitter thread. So I'll go back and forth with the live as well. The folks from the USA, I think you are watching the election results as well. I've been trying to figure out, and now there are 2-3 sleepless nights when I'm trying to see when the results break. Anyways, so Green Parrot, I know you're concerned about the safety of chloroquine. However, do you think it could be used at a low dose once a week for prophylaxis when hydroxychloroquine is not available? I only mean prevention, not treatment. So Green Parrot, chloroquine is much, much more potent compared to hydroxychloroquine and more toxic than hydroxychloroquine. The only study that came out of Brazil about the chloroquine had to be stopped because of its toxicity. Because of that, I actually do not have data that can back up using chloroquine as a prophylaxis. So even if I make up something, it would just be Mubin making up something. There would be no data backing it up. And it is quite dangerous and unethical for me to say that. So because I don't have data, I would not say that chloroquine is okay for prophylaxis. Green Parrot has one more question. Hello, Dr. Bean. I'd love to hear your comments on isoprinosine. And so what I did was I have taken this as a to-do. What happens is I try in the open forum, I try to avoid the mechanism-oriented things because they need a little bit of explanation and then the whole thing becomes longer. Plus, that topic, which is very valuable, for example, this one, when it is embedded in the open forum, it is lost in there. So I would do a separate discussion. Drew says, my friend from South Africa, ivermectin is safe, early treatment is crucial. Absolutely, absolutely. Scott says, so Scott has one more question a little bit above. I think this question is related to Scott's brother who has COVID-19. So he's saying, sense of smell gone, symptoms like fever present, is there telemedicine? I believe practitioners are afraid to treat for mild COVID. He's 62, good health. I can't give him experimental medications like ivermectin, ACQ, etc. I do research. Is this common care? Many are asking. So Scott, I have always avoided being specific to one patient as long as if they're not my patient. It is unethical, unprofessional, and it is dangerous for me to kind of just looking at a tweet respond without knowing their history, without knowing their body, without knowing their labs. So once again, in my opinion, the best way forward is all those discussions that we have done about famotidine and ivermectin and hydroxychloroquine and zinc and others, but basically it should be his doctor that would look at his labs and decide what is the right thing to do. Bart Brown says no access to hydroxychloroquine. Would PQQ work similarly? So I have the PQQs. I have the PQQ open here. Some of these links are very extensive on ads, and then they just churn my computer. So the pyrroloquinolone, quinone, is kind of similar family, but I haven't seen its use or any study to back up for its use for COVID-19. So I would continue to stick with what is backed up by data for what there are studies available. Green Parrot says, is ivermectin contraindicated in patients taking SSRIs and benzodiazepines? So very, very, very good question. And please see this. I have one article over here. This article is about ivermectin with hydroxychloroquine, I believe. What were we talking about here? Hydroxychloroquine and SSRIs. So yes, if you see here, hydroxychloroquine and these psychostimulant or psychomotor or drugs that affect the brain activity, they can be toxic. So please be aware. On the other hand, Diazepam, this is a very important one. And the folks who are here, I think this is a very important thing for everyone to note. Diazepam is used as an antitoxin to or antidote to hydroxychloroquine poisoning. So what is happening is in this article, and I have put the link in the description, in this article, the authors or researchers are talking about COVID-19 and many people taking hydroxychloroquine, and then they are developing toxicity of the hydroxychloroquine. And they are over here, they're sharing what is the antidote to the poisoning. So diazepam is used as an antidote. So check this out. So they have two set of drugs for antidote or antidote. So here is one set. I would let you read it. And if you're a medical professional, I would encourage you to read it, because people are taking hydroxychloroquine and then getting the side effects. And when they come to you, your dilemma now is that the hydroxychloroquine is going to stay in their body for next, let's say, 26 days to 54 days. And now how do you get it out to stabilize their body? So there are two ways. There is a symptomatic treatment of stabilizing the heart system and the sodium channels, and then there is treatment through diazepam as well. So if you see here, the second component involved directed therapy with high dose IV diazepam and epinephrine. So they've talked about the dose here. How does diazepam actually help against hydroxychloroquine? These drugs directly affect the pharmacological mechanism through which hydroxychloroquine exerts its toxicity. So what is that mechanism? Animal models of chloroquine overdose demonstrate that when diazepam is administered, whole blood concentration of chloroquine is increased while cardiac myocyte concentration of chloroquine decreases, which means that the diazepam may mediate displacement of chloroquine from sodium channels in the heart. So one reason for the cardiac arrhythmias with hydroxychloroquine or chloroquine is that the sodium channels get affected, that then cause arrhythmias, and diazepam can actually go and displace hydroxychloroquine from those sodium channels, restoring the normal behavior of the heart, which is very important. And so any medicos over here, please realize that when people come to you with hydroxychloroquine toxicity, here is a possibility. The second reason that diazepam can help against hydroxychloroquine's toxicity is that it may exert antiarrhythmic effect by binding to cardiac myocyte GABA receptors. So there are GABA receptors on the heart muscle, and then it can bind there and help with the arrhythmia. Now going back to the original question here, and that is, how about benzodiazepines? So although I have looked at hydroxychloroquine, he's talking about ivermectin. Ivermectin itself would not cause anything to the benzodiazepine. On the other hand, with the SSRIs, you have to be able to see if there is anything to do with the blood-brain barrier, and would ivermectin then cross, and then it can cause interactions. But I wanted to make sure that the hydroxychloroquine toxicity is also looked at. All right, so then continuing on, there are a couple of questions here. One question is, so this is, I believe, Ragadis Sahel. Why does children have infected, why are children infected severely by other viruses, not SARS-CoV-2? However, their innate immune system is strong and they have high number of NK cells. It is the same immune system. Very good question. And Ragad, we don't know how immune system responds or why immune system responds differently to different viruses. Every virus comes in, and bacteria comes in with their own set of antigens and their own set of toxins and their own set of binding proteins. So how does a particular virus or bacteria modulate our system, and then how does our immune system react to it, is unique per virus and pathogen. So in general, we can say that yes, for SARS-CoV-2, this is how the innate arm works. But clearly, we know that most of the respiratory infections with the common cold are actually more common in children than adults. So adults handle them well, and children do not handle these well. On the other hand, in case of SARS-CoV-2, children handle the SARS-CoV-2 better and adults do not. Yes, it is the same immune system, but we have done a detailed discussion about why children handle it better. Now, why is the same mechanism not applicable for common cold or rhinovirus or flu? Every virus has a different way of triggering and poking our immune system. Good question. But that is the basis of immunology and this bacteriology and virology, that all of these pathogens react with us and interact with us differently. Jaro Franta, following up on previous question, appreciate the answer, but you seem to have missed this European study. Any further comments, in particular comparison of sulfate polysaccharides, carrageenan, sulfate? So what I'll do is this, Jaro, I'm sorry that if I missed it, I have taken this antihistamine nasal spray. So the basic idea over here is that this study says that antihistamine nasal spray are a potential for anti-COVID. However, I have not seen any study behind this. This is just an idea that, hey, this is possible, but I've not seen any study. So till the time I see a study, I'm not going to be able to comment on it. Ragad has one more question. We have studied that MSC1 only presents viral antigens to other cells, but most of the time you are saying macrophages do that. However, they are MSC2, not 1. I was confused. Can macrophages do that? So Ragad, as I try to look at your profile and try to make sense of Arabic, which I do not know, but I see here the word Daktura. So I think you are a doctor. And if you are a doctor, I think this should have been clear early on. So let me explain it. Here is a cell, and let's say this cell is macrophage, right? We have 3 kinds of cell that can present, that are professional antigen presenting cells. This is like in a community, there are policemen. Not everyone is a policeman, but there are, from the community, there are policemen as well. So these macrophages, dendritic cells, and B cells are called professional antigen presenting cells. And you are correct that when they present an antigen to naive T cells, they present them, so this is naive T cell, they present them on MHC2. That is correct. At the same time, we studied in medicine that all nucleated cells, all cells that have nucleus. For example, we have RBCs that do not have nucleus. We have platelets that do not have nucleus. But all cells that have a nucleus can also present antigens on MHC1. MHC1. So clearly, a macrophage is a nucleated cell. So it can present antigens on MHC1 just like any other cell which will get infected. Plus, it is a policeman as well. So it also has handcuffs with it, and it can also present antigens on MHC2. When it presents antigens on MHC2, then it can actually have the adaptive arm amplified. When it presents antigen on MHC1, then it can connect with the natural killer cells, or it can connect with the cytotoxic T cells and take care of its own infection with them. So professional antigen presenting cells can present on both. So there is another question by Raghat, then I'm gonna come to the live stream. I'm sorry if there are discussions here which I'm not looking at. Even long haulers are showing different symptoms. Do you think, doctor, that the virus may have a persistent stage? So I have talked about long haulers many times. And in this context, I also want to discuss this. I tweeted a comment that was sent. So a long hauler sent me a donation. With that, they had sent a comment that I tweeted yesterday. He was saying that he's 40, I believe, 40 years of age. And he has been a long hauler for 7 months. And for 7 months, he had tried, for example, from Math Plus, the anti-inflammatory things from there, for example, I believe thiamine, vitamin C, etc. And he said that did not help. Then somehow he found my video about long haulers, and over there he saw that steroids, I have been using steroids. So he then requested one of his doctor friends to give him steroids, administer steroids. And he said it worked like magic, and within a few days I am recovered. So this is 7 months of long hauling. So one good news that steroids can help reset our immune system in this case. Now, Raghat's question is, long haulers, what is the reason for long hauling? And I have discussed it many times. I would say it once again. Long hauling, if we just assume or agree on one basic definition, and that is somebody who becomes COVID-19 positive and then for weeks and months afterwards still has symptoms, still has issues. So let's call that long hauling. Now that can be because of, for example, somebody had severe case of the infection and their lungs got damaged. And now those lungs need time to be repaired, so that they will be in long haul state till their lungs are rehabilitated. So this is an organ damage, and that needs repair, and that need time for repair. That is one possibility for long hauling. Another possibility is persistent virus. And again, how much is this correct? Do we actually go in carrier state? It is still not confirmed, but it is possible. The way to think about that clinically and medically is very simple. If a patient has symptoms, that means there is something going on. Now, is that the something that can be going on are basically two things. Either the virus is sitting in the body and causing our immune system to go nuts, or our immune system has gone nuts and the virus has gone, but the immune system is still dysregulated. So if I put that over here, immune system dysregulation. And of course, we already talked about the organ damage. So if there is an immune system dysregulation, so somehow give me 1 second. So if there is immune system dysregulation, in the most cases I've seen steroids help it. If there is persistent virus, ideally persistent virus should not be helped by the immune system. So when I give immune system steroids, I'm saying that persistent virus should not be helped by steroids. So when I give steroids and people become okay, that means they do not have a persistent virus, they just have a dysregulated immune system. But if there are people who have persistent virus and they would not respond to the steroids. Similarly, if there are folks who are still in reparative stage of their disease recovery, then they would also not respond to steroids that well. So my strong belief is that there is an immune system dysregulation, because till today, anyone who is a long hauler, in my patients, when I use steroids, they become okay. So I hope that answers that question. So before I continue with Twitter, I'm going to come here on the live chat and talk with you all. So what's happening here? Let's see. Jenny says, what if the long haul is forever? Jenny, again, if we keep these three things in mind for long hauling, there are people who are on ventilators. They may get lung damage that is forever, because they would develop baby lung physiology. Their lungs would become scarred and shortened or shrunken, and they would never recover to the full extent. And they are going to become long hauler forever. Similarly, cardiac damage can become long hauling forever, or the vascular system damage or the neurological system damage can become long haul. However, if it is immune dysregulation, luckily, fortunately, in case of COVID-19, so far for my patients, giving 1 or 2 pulses of steroids have them recovered. So I hope it does not happen that there are people who are long haulers forever. I think what is wrong at this time, at least in the US, is that doctors are not acknowledging or recognizing that there is a long hauling state, and they are not able to figure out how to treat them. Treatment is very simple. Try a pulse of steroids and be done. M. Gregory says, lockdown is making me nuts. I understand. Anthony says long hauling is hell. Absolutely. And steroid with your doctor's advice. Here the problem is that even doctors are not advising it. So there's a question from John Stark. Do you still so if you have a question, can you please put the word question? It helps me sort out the questions from the stream. So John Stark says, do you still think that the quercetin and zinc works well as a prophylaxis against COVID? I don't have access to hydroxychloroquine. Yes, they do work well. However, ivermectin is good as well. And the most basic thing to do is to at least keep your vitamin D levels up, use melatonin, use zinc, use quercetin. If you cannot find quercetin, then use red onions or red apples or red skinned fruits, and so on. So I've talked about many prophylactic things. So quercetin and zinc should work if you don't have access to hydroxychloroquine. Arun says, sir, do you think after taking so much ivermectin, helminths will be resistive to ivermectin? No. So luckily, the worms so far cannot change themselves like bacteria and viruses, because they are a little more bigger evolved things. So they would still be a target of this. I was actually thinking last night, so many of the thoughts I do is while I'm sleeping or going to sleep. I was thinking that if ivermectin was made available globally because of this COVID-19, it would actually cause so much of deworming that there is going to be so much health in many of the underdeveloped areas. And this is nothing but good. So when you already have C19, would you continue to gargle? It would continue to reduce the viral load in the throat. So it would help symptomatically, plus it would help you shed less. Okay, so I'm going to see if there is a question by Stratilize. There is a difference in duration. There is difference in duration of treatment. I read Math Plus as 2 days. Yours is 6 milligram twice per day for 6 days. Is there a concern if a local doctor is prescribing same dose but for 14 days? So Stratilize, I think you're talking about ivermectin. So the math plus protocol is slightly different. Dr. Marek is by the book, and so he has a different way of presenting the protocol or the dosage here. What I have been doing is something that I've tried with my patients. I started off about 6 months ago with 1 or 2 doses in a week. And then as I saw that this was efficacious and it was helping, I then increased that dose. And now when somebody is actively in this situation, for example, I talked about this 70 years old person who was ischemic heart disease patient plus diabetic and had the COVID-19. When I give them daily ivermectin for 4 or 5 days, they actually recover very fast. Maybe I'm overdoing it, but so far there have not been any side effects, and so far patients have been recovering very well. Maybe 1 or 2 doses are sufficient. That needs studies, and I haven't done those studies, and I do not have those studies available. Thank you for honoring religious and spiritual diversity. Many of us do. Absolutely. Although the downside for me is that it is funny, my own folks from Pakistan or from India and then Muslims, or they just continue to hammer me that somehow I am just not trusting. Anyways, I feel that at this time, for all of us to be relaxed, to contact whoever we believe in, and to be relaxed and calm and restful and be less scared, less fearful, whatever makes us do that is very important. John, question: is there any medical study of getting COVID-19 from meeting outside without a mask if you're a social distancing? John, I have not come across that. And I would suspect that if you're not wearing a mask, but you are at a social distance and this is an open area, then ideally you should not get COVID-19. But that doesn't mean I'm an anti-masker. I wear mask when I go out, and I would continue to ask folks to wear masks. Claire, yes. So for this doctor from Greece, he is not developing antibodies, but he is not very intensely symptomatic either. So it is his innate arm and the cytotoxic arm that is taking care of things. So Aniana Pozo says, what causes a 20-year-old person with COVID die of blood clots? So we have done this discussion in the past that hypercoagulability with COVID-19. So COVID-19 can cause blood vessel damage that, excuse me, that can in turn cause the clots formation and death because of that. Logic says, have you had time to research alpha lipoic acid? Not yet, Logic. So please remind me next week as well. I keep taking these notes, but there are so many topics to discuss that I cannot get to all of them. So let's see. Yeah, so Faith and Grace says, hi, Dr. Bean, have you heard about COVID-19 infecting minks, mutating and spreading to humans in Denmark? Yes, I did. And I also heard and read that they're going to kill them all. I love animals, as you know from Luffy and Kyrie. I love animals. I love life. So I always become distressed when I hear these kind of news. I kept thinking, couldn't they quarantine them instead of killing them? Couldn't they allow them to become recovered from it? Anyways, yes, I heard the news, and I'm very sorry that they are going to kill them. Okay, so I'm going to go down to the bottom and see if there are any more questions here. So Kelly Venga says, I've tried steroids, no recovery still. Did the kit from Dr. Patterson. I have high interferon, elevated RANTES, and elevated IL-2, 4, 6, 10. I wonder how one would shut this down. Kelly, the answer still is going to be steroids. So the question is, if you can talk with me on Twitter, tell me what steroid pulse have you taken. Sometimes more than one pulses are needed, and I would like to know what dose and how did you take it. Because at the end of the day, when you take Dr. Bruce Patterson's kit and it shows that the interferon is elevated, or RANTES is elevated, or IL-2, 4, 6, and 10, what that means is still the same. So if I go in here and I very quickly draw the immune system, we know that this is, let's say, a macrophage, and then this is a naive T cell, and this is a T helper 2 cell, T helper 2, and this is B cell, and this is T helper 1 cell, and this is a cytotoxic T cell, and this is a naive T cell, and this is a macrophage. Eventually what happens is these guys are producing interleukin 1, interleukin 6, interleukin 8, then interleukin 12, 12. These guys are producing interleukin 10, interleukin 4, interleukin 5. These guys are producing interleukin 10 plus interleukin 12. Then they are producing tumor necrosis factor, plus all of these are producing RANTES. So at the end of the day, this is how the immune system works. It produces all of those things. So how do you temper them down? Either you bring in things that are going to be individually modulating, for example, Anakinra for interleukin 1, or tocilizumab for interleukin 6, or interleukin 12 blockers, or RANTES blocker like leronlimab, or you bring in steroids and calm the system down. So I think that the steroids are the one that need to be done. The test that you showed is just simply telling that the immune system is dysregulated. Anthony says, Salvador Tehran, good question. I'm long hauler with very elevated IL-6. Anthony, have you had a steroid pulse? So Salvador says, why do you think that anti-IL-6 monoclonal antibodies don't work? Sarilumab and tocilizumab showed no benefits in 2 large trials. The reason for that is the thing. So good thing your question is kind of related to this. So we are saying that this immune system, let's say, has become dysregulated or amplified, right? Now, let me take the question off. Now, if this has gotten amplified, IL-6 is being made, IL-8 is being made, IL-1 is being made, IL-12 is being made, IL-4, 5, 10, and IL-17, IL-23, tumor necrosis factor, GM-CSF. There are so many cytokines that are being produced. Out of all of them, if we just go in and say, you know what, I am just going to shut down IL-6, that is not going to do a lot if the immune system itself, whole of it, has become dysregulated. That is why tocilizumab-like drugs are not functioning very well, because we are only doing a spot suppression of the immune system. So ideally, steroids should be used to suppress the whole. This is like, Windows computer, where we used to have this joke that every time you need something to do with the Windows computer, the very first thing is to shut it down and reboot it. This is a similar thing. This virus, unfortunately, converts our immune system into a Windows computer, and we need to kind of reset it. And that reset button for Windows computer of our immune system is steroids. So I hope that makes sense. So Simple Garden says, I've done 2 courses of steroid pulse, 20 milligrams 7 days, then 1 week of wean. That is a good pulse. 20 milligram is decent. And what happened to you? No response? Kara, good morning. Thank you very much. All right, so I'm going to go to the Twitter side for a second and just answer a few of those. So Anthony says, for long haulers, Dr. Patterson is recommending steroid taper plus CCR5 inhibitor. Yeah, so actually, even if just a steroids, that should work, because steroids include RANTES suppression by suppressing the whole immune system. So let's go back to Twitter for a second. This is an interesting one. Woman sheds coronavirus for 70 days without symptoms. So I have it open over here. And the reason is that she continued to shed the virus because she herself was immunosuppressed. Because she was immunosuppressed, she continued to have the virus in her, and the virus got cleared very slowly. And so meanwhile, she kept shedding it. So that is actually understandable for immunosuppressed, either because of some genetic or other pathology, acquired pathology, or immunosuppressed because we are giving them medicines to suppress their immune system, for example, for cancers or transplants. Such patients have difficulty in clearing out the virus. And so when they are not able to clear out the virus is going to stick in them. In some patients, the virus is going to cause a lot of destruction because the immune system is not checking it. Or in some patients, the immune system is at a very low rate, still responding and clearing it out, but is clearing it out in a slow way. So this 70 days shedding is not that she was a carrier, but instead her immune system was not that, was suppressed. So good link. Emily, thank you. So then R.P. Varal. Hi, Dr. Bean. I have access to chloroquine and not hydroxychloroquine. Can they be substituted and combined with ivermectin? Hydroxychloroquine can be combined with ivermectin. I can never stand behind chloroquine. It is 5 times more potent. It is more toxic. I have not found the right dose of chloroquine for COVID-19, especially for prophylaxis. So I have no idea how to use chloroquine in this situation. Tony Karalika says, cool beans, have you seen this emergence of antiphospholipids? So I'm going to talk about this in another day or so. Anthony Walbrecht, what's the difference between SARS-CoV-1 and SARS-CoV-2? Is it possible for CoV-2 to live in the brain for months? So first of all, the difference between them, they're both cousins. So they're both similar. SARS-CoV-1 connects with our cells with a different type of receptor. Instead of ACE2, I think it connects with DPP4. SARS-CoV-2, the current one, it connects with ACE2. That is one. Secondly, their genetic material or their genes are about 86% similar. Then there is a diversity in genes as well. So their enzymes and their proteins are slightly different. Now, can SARS-CoV-2 live in the brain for a long time? I haven't heard of that yet. Remember, I had done two videos about a unique case. That was my class fellow's son who died of meningitis, and he had COVID as well. And we still do not know, was it the SARS-CoV-2 causing him meningitis, or was it the COVID-19 brought him down and some other thing caused meningitis? So far, I haven't seen in intact blood-brain barrier patients that they have the SARS-CoV-2 going into their brain. Yes, we have seen that anosmia occurs because the SARS-CoV-2 goes to the roof plate here of the nose and roof of the nose, and then causes infection there of the olfactory system, which then causes the anosmia, plus the lymphatic drainages are obstructed, which then causes the headaches and those things. But so far, I have not seen that SARS-CoV-2 connects with the nerves and then enters the brain in an intact brain. Atlas the Husky says, any studies on long-term weekly dose ivermectin, I mean for safety, side effects, etc.? No, not so much efficacy. Hope that makes sense. Yes, so Atlas, therapeutic dose for deworming, once in 6 months or once in a year, 150 to 200 microgram per kilogram body weight. And contraindications we know. We had not seen long-term usage as a prophylaxis of this drug in the past. This is the first time it is being used. So I think we are going to find out that if somebody has been using it for a long term, what will happen? So good question, but there is not enough data yet. Okay, so Kobayashi Maru, you have a bunch of preprints over here that are really interesting. So what I did was I took notes of them. I would discuss them as well. For example, here you're talking about antihistamine, and then above you have some more of those. I cannot explain the mechanisms in the open forum for all of them, so I'm going to talk about them separately. But great comments here. Buddha Jiva says, thanks a lot for making a video on this and answering. So this was Buddha Jiva's, the ivermectin is working in India that I did yesterday. So this was Buddha Jivi's, he had pointed it out. So Buddha Jivi, you're very welcome, and thank you for sharing it. Ragat says, thank you, Dr. Bean. I feel proud to be one of the cool beans. I learned a lot. Very, very good. I am actually very happy and proud of the cool beans. I believe that our tribe, the cool beans, I think we are the only one in the world at this time for COVID-19 that understand the mechanisms to this depth that we can think about them, and we can then think about how to protect ourselves and the people around us. So when I started it, it was 1 or 2 videos, and I was very thoughtful that what is the benefit of me doing it. And now there are 205 or 6 or 8 videos, and there's a lot of topics in there. And I think it has become an asset for the community. All right, so questions here on the live side. Alexandros, looking into the MRI pics for the COVID entering the brain. Look in the MRI pics for the COVID. Understood. But the question is that in the people with the compromised blood-brain barrier, or is that in the healthy people? Jude says, question, please remind us about the dosage of quercetin and zinc in place of hydroxychloroquine. Jude, can you please tweet that to me, and I would respond to that, because I'll have to look up. I'm going to actually go check Dr. Zelenko's recommendation for this. OA8, I agree. So COVID-19 can infect brain. I totally understand that. Question is, in the healthy people or the people who had brain infection or blood-brain barrier compromised. For example, God forbid, I develop COVID-19 today. Then I develop something else that can cause meningitis. And now the COVID-19 gets a chance to enter my brain and cause infection. Good, that can work, and that can kill me. But in the absence of any other infection that has made my blood-brain barrier vulnerable, can COVID-19 directly enter the brain and primarily cause its own infection there? I think that is something that is not clear yet. So to both Dr. Alexandros and to 008 KLM, agreed that we have seen the brain infection. The question is, was it direct? If it was direct, then out of these 40 million people who are the cases for COVID-19, there'll be a very difficult situation. So my theory, and again, I'm just talking about a theory, so I may be wrong here. My theory is that COVID-19 enters brain when the blood-brain barrier is compromised because of something else. Or the patient becomes so weak with the COVID-19, for example, the lung damage and the cardiac damage, it becomes so weak that the blood-brain barrier, because of the inflammatory proteins, the blood-brain barrier also swells up and is inflamed, and COVID-19 enters the brain as well. That is possible. But I'm talking about a healthy person. So this is a very good question, Ayush. Ayush says, in mild symptomatic patient, is it good to start low-dose steroid with DC, zinc, ivermectin? So this is exactly the discussion, and let me actually see. I was with this doctor who has a COVID-19 and he started on DEXA. Now his mother has COVID-19, and I asked him not to start on steroids for a few days. Let the immune system first gear itself up, and then we'll give steroids. I don't want to suppress immune system right in the beginning. However, having said that, I have seen many doctors, outpatient doctors, who start delta cortril right in the beginning as soon as a patient visits them. I think it is dangerous, but doctors have done it. Laura Reed says, Dr. Bean, you played it so cool on not getting sucked into the pointless debates and stuck to the info and knowledge. Thank you. You're very welcome. And you do not know how much how much hard work I have to do for that. There have been stalkers produced out of this, who I have actually have emails and texts and phone calls and voice messages and the Facebook and the Twitter's accounts, who have challenged me, wanted to debate with me. Then they stalked me when I said I'm not going to debate with you. Then sent me emails threatening me that they would put me in jail, and they would do lawsuits on me for not talking with them because they have things that I'm not considering, to a point that for one person at least, I became afraid that they're going to come to my home after what they had been, how they were stalking me. So as much as I'm trying to stay away from those debate parts and just trying to put the knowledge in front of you so you can figure out how you want to process and digest that and align it with your own knowledge base, it is actually difficult as well, because people do challenge me and kind of sometimes threaten me. Anthony says, Dr. Bean, do you have Cash App? No, I don't. So I will look at it. Cash App. I would look at it. I do have Venmo. John Corina. I have PSA. I'm taking, will quercetin compromise the medication? John, can you send me a Twitter message so that I can actually research this for you before I can just open my mouth about it? So John Sider says it is a doggy worm pill. It is actually for humans as well. But again, the animal version is not for humans, but for human deworming, ivermectin is also used. So AK says that he has gotten 101 fever, 4th day of fever gone, but loss of taste and smell. So deep breath, took ivermectin. So AK, tell us more about ivermectin and how many days have you taken it? So Simple Garden says, I've done 2 courses of steroid pulse, 20 milligrams 7 days, then 1 week of wean. Then how long after did you do it, and what happened? Are you still not recovered? Kara, you're very welcome. All right, so let's see more questions here. Stratilize says, thank you. Because of you, I'm able to line up multiple family members that now have COVID. We have a doctor using your protocol now. Excellent. I hope that you all stay safe and healthy. This is the objective of this all. This channel is not a channel to sit here for me to debate people and to tell them that I have read something and you have not. That is, in my opinion, is a stupid thing to do. I think the most important thing is to bring knowledge and make it accessible for all of us so we can all protect ourselves and people around us. 1x2 says, Solantra is an ivermectin cream used to treat rosacea. Would it be of any use on COVID? No. So the problem is that we need ivermectin to go into the body tissue cells to help us there. Solantra is a cream, so the absorption is not enough to be useful inside the body. So Anthony says you should debate them. I'll be the referee. Anthony, you just want to see things happen, huh? So Kelly says, LMAO, stalkers, I love it. He's watching you now. Yes, he is. I actually think very many times after every video that stalker is actually watching my videos, and sometimes I talk about them. That must make them even more upset. So I should not talk about them. Alexandros, please look at the link above. My is that even if the olfactory nerve is infected and it shows in the MRI, in 20 days, the sign goes away. Yeah, so Alexandros, I had done a discussion. So this is Dr. Alexandros, very good friend of mine. Dr. Vasaras, I had done a discussion that the actual infection on the olfactory area is not to the olfactory nerve, but the supporting connective tissue around it. Because of that, when the connective tissue swells up, and there is a relative ischemia in the olfactory area, that reduces the nutrition of the olfactory nerve itself. That is what causes anosmia. So Dr. Shoaib says, are you planning to discuss trial on honey and Nigella steva? Absolutely. I just would do it next week. Absolutely would do. All right, so gonna go back. So I haven't yet set up Patreon yet. I think I should set it up. I had only set up a PayPal account, and I think not everyone likes to use PayPal. So I would set up a Patreon account. All right, so some more Twitter here. So this is a good one. Honor UKB says, question, can Listerine gargling after affect throat swab for a PCR test, please? So I had thought so, that when you have done the gargling and it has kind of reduced the viral load, then the throat swab should be affected. But I was mistaken. And how was I mistaken, and how did I know I was mistaken? And then I corrected it and I understood why. The Cool Bean, who had the COVID-19, 50 years old, he actually had a throat swab after he had gargled, but his swab still came back positive. And now that makes sense, that even when the throat swab can reduce the viral load to 95, 93, 96, 7%, the swab can pick up very small number of copies of RNA and still do RT-PCR on them and amplify them and then come back and say positive. So we may reduce by gargling the viral load enough that it does not hurt us too much, but for the sensitivity of the test, a few copies of RNA are also enough to be amplified and then be detected. So what I found out was that gargling does not affect the PCR testing. So good question. Ruchi Banthia says, can you please elaborate the role of neuropilins? So neuropilin, Ruchi, I have to work on this one. Somebody else had asked me to do this topic as well. So give me this next week and I'll talk about neuropilins. Honor UK says, do you think that hydroxychloroquine may have impacted on the results of the remdesivir in the study you covered? Possible. So this is why when you are doing studies with more than one drugs, it is possible that one drug is doing the function and you're kind of attributing it to the other one, or one drug has a side effect and the other one is now blamed for it. So it is possible that there is a mixture of interaction plus both of them are adding to their questions, to effects and side effects. Helen J. Knox says, you absolutely have to be here in the UK. It's a disgrace, isn't it? I think she is responding to Scott. So Scott, this is same Scott who was talking about his friend in an earlier message. My brother had mild symptoms, fever, fatigue on 10/26. He had a positive PCR test for COVID-19 with results on 10/28. His GP did not recommend any antiviral or supplements. The advice was to sequester at home, but go to hospital if he has shortness of breath. So Scott, this is what is happening in the US as well. And I think it's so wrong at this time. After 10 months of understanding this virus and this disease, now it has become criminal not to treat people right in the beginning and aggressively. Did they not do this with the President Trump? Within 2 days, he recovered. He's not a superhuman being. Actually, his body weight and the way I don't think he exercises a lot, I think that he was actually more vulnerable. But aggressive early treatment saved him. That should be actually done for everyone, instead of saying, oh, you know what, just sequester yourself at home, just go in a quarantine, and then if you develop shortness of breath, you come in. I actually made a call to our hospital here, and I said, I have cough and fever. And the question they asked me was, are you concerned about it? If you're not concerned about it, we would just simply say that you stay at home. If you're concerned about it, tell us what are your questions, we'll try to answer. So they were doing more psychological help to calm me down and convince me to stay at home than to say, let's treat you. I think that has become wrong. And this is where now I like those countries at this time who do not have that stringent controls, and where doctors are able to easily use ivermectins or hydroxys or zinc or vitamin Ds or other things, and they are able to take care of their societies much better than here. Fuzzy says, could you please cover nebulized hydrogen peroxide. Fozzie, I'll have to have the link. So can you please share the link and I'll talk about it. All right, so I'm going to come here for a second on the live side. Alexandra says, should we expect that a positive RT-PCR at 25 cycles would show a patient that is shedding and a positive show an asymptomatic patient that is not? It is possible, Dr. Vasaras. So this is what I do not know exactly. Remember, so there's been a fight going on to say 40 cycles or 33 cycles or 35 cycles. It is a question in my mind as well, that what are the cycles that are sufficient and are indicative of the virus that is in enough quantity to infect the cells versus virus quantity that is just sitting in the mucous membrane, not in enough quantity to infect the cells. And we should be able to differentiate between them. That means when the RT-PCR happens, as you are alluding to over here, we should be able to say at 33 cycles, it was positive or negative. At 35 cycles, it was positive or negative. At 40 cycles, it was positive or negative. And based on that, we can actually then see, is it possible that the patient may actually have the active infection going on, or is it possible that there is just some presence of the virus RNA in the throat and nose? Very, very good point, Dr. Vasaras. So Fatima Ahmed says, I'm a long hauler. I'm persistent with sore throat, muscle aches, chills, fatigue, and heartburn. My doctor refuses to give me steroid. Just give me famotidine. Steroids is the answer. So John Snyder says, look, there is no blue screen saying Windows has crashed, so no way did Bill Gates design this. I actually saw one of the memes in the beginning of the COVID-19 where somebody had said that, oh God, can you please reinstall 2020? It has a virus in it. So there is a virus in it. All right, so Straighteleye says, if you are suspicious about continued virus after steroid for a long hauler, would you retreat them with ivermectin like the 70-day shedder? I would actually first test them and see if, number one, if they have antibodies, and number two, if they have RT-PCR positive. Then based on that, I would decide what to do. Of course, an antiviral should be given. Good question. So back here, let's just plow through them as well. Kobayashi Maru says Anakinra. So Kobayashi, I have talked about Anakinra before, and I have put that link in the description. I think the video is going to be somewhere over here. In this third part of the Math Plus protocol, I've talked about Anakinra. Kelly V, question, do we know what causes everlasting headaches with COVID? What is the mechanism behind this? So Kelly, I have done this video called Brain Fog, Myalgia, Depression, and Fatigue in Long Haulers. So the basic idea is one of the reasons could be that there is a glymphatic system not working correctly. That causes the increased pressure in the brain, and that causes headaches and myalgias and fatigue. There could be that the virus, as we were just discussing, that maybe somebody's blood-brain barrier is not that protective and the virus has actually entered the brain. So then there would be a different situation. Or there could be that because COVID-19 caused a person to become weak and become sick, and some other virus became an opportunistic virus or fungus or bacteria and started an infection in the brain. So there can be many reasons for the headache and for the brain effects. One of the known reasons, or hypothetical reason, not known, is that it is possibly glymphatics because of the nasal system's inflammation because SARS-CoV-2. Very good question. And please, I would recommend if you can watch the video that I just showed. And all of these links are in the description. So this is another Kobayashi Maru's, that colchicine and other, there is a protocol here. Kobayashi, I would look at this protocol and then see if I can talk about it. Similarly, metformin. So I have that open here, that metformin. I have it open over here in the description that metformin is associated with reduced mortality. So the basic idea of the study that Kobayashi has shared here is that people who are diabetic, and if they are on insulin, that insulin does not help them against COVID-19. But if there are people that are diabetic and are using metformin, somehow in them COVID-19 related mortality is less. So I have to still go through the paper to understand why is that less and what is the mechanism possible. So I haven't looked at that yet, but Kobayashi, thank you very much. And I took a note of this and I'll discuss it. Kobayashi has one more, aprotinine, which is another, aprotinine is also another protease inhibitor, just like bromhexine. So I have done a discussion for bromhexine. So definitely they work. I am still curious at why bromhexine studies are not showing it to be that effective, but in theory, protease inhibitors should work. And I have taken, Kobayashi, I've taken note for this one. I have to actually look at it. Vic RV, what are your thoughts on dipyridamole? So I have taken this one as well. I think there is some, so this is the metformin. So if you see here, there was no association with insulin, but relative to those not receiving diabetes medication, residents taking the metformin were at a significantly reduced hazard of death, 0.48. So that is like 48% less. Confidence interval is 0.28 to 0.84, which is actually significant within the third day of diagnosis. So metformin somehow has a protective role. Why, I do not know yet. Then this was the aprotinine, that is the protease inhibitor like bromhexine. And so, yes, I have talked about it, that there, in theory, there is a benefit. And then this one is the article about nitazoxanide in mild COVID-19 patients. So I would do a complete discussion about it. Then going back here, Leo the Buckeye question, the high rate infection in the USA is not correlated to the hospital rates or death rates any longer. I am wondering if we are counting cases for exposure rather than infection due to PCR method. As a result, people may test positive twice or 20 times but never sick. So that is a discussion we were just doing, Leo, that it is possible that some of us are we just have the virus here and it is not going to do too much to us. But the PCR sensitivity is so much that it is kind of saying that you are infected and we are saying, yeah, positive. But maybe that virus is not sufficient in quantity, in viral load to actually impact us. Or maybe just the virus is sitting here just like other human coronaviruses and we have actually become immune to it. So I always recommend if somebody can get, they should get their antibody test and their RT-PCR. So good point. Kobayashi, thank you very much. This was not a question, but something that he wanted Cool Beans to look at. Thank you. Then this question, a basic question about quercetin as a zinc ionophore. Does the amount of zinc that can be transported inside a cell depend on the amount of the quercetin levels in the blood? So basic answer is the following. So let's say we have a cell here and we have an ionophore for zinc. If ionophores are more, but zinc is less, then these are extra empty channels that are useless. But if zinc is in the right amount, then even if we have extra ionophores, the right amount of zinc will go in, because as the zinc would enter the cell, there will be a concentration gradient that will be produced and no further ionophores will be used. So it is not just that if we have, instead of one door in a house, if we make 100 doors, that will make more people to come in. If the person who live there is like 4, then even if there are 100 doors in the house, there are still 4 people who are going to go in and out. So the zinc's quantity entering the cell would be decided by the concentration of the zinc inside the cell instead of the number of ionophores. Yes, if there is more zinc outside, less zinc inside, zinc has to go in, but ionophores are not available, then we have a problem. So to answer your question, if you are taking the right dose of ionophores, then it is just, if you're taking the right dose of ionophores, then the zinc amount that we are taking on daily basis should be sufficient. So hopefully that answers that question. So continuing on, then we have the question here from K-pop super strong. And the question is, what are your 10 recommendations to the next administration to solve the pandemic and moving forward? It is a good question. So I'm going to answer this one and then come back to the live stream here. So let's see. The answer is, I had actually written it down. So here is what I think we should do. And whoever it is, Trump or Biden, I just hope that these things can be implemented. So look at this. Create a board to review the latest studies. Imagine what we are doing here as Cool Beans. What are we doing is we are reviewing latest studies, educating ourselves, then trying to see what is our confidence in the study and its effect, and then deciding that should we use that drug and adapt it. This thing should have been done at the level of CDCs and FDAs, or as a separate COVID-19 management committee, which we do have today. Mike Pence heads it, but that committee has, I don't know if it is more political than actually useful. So number one, there should be a committee that should look at the studies. Their job should be to look at these studies, then figure out what to do. And now what to do should be, what should be the prophylaxis, what should be the early treatment, what should be the situation for the mild and moderate cases, and what should be the situation for severe cases, what should be done for long haulers. So all of these things should be figured out by a committee, and there is enough information available that they can go back and they can say, okay, here are the things that need to be done. So that is one. Second, adapt the protocols. What should be prophylaxis? Once that protocol is adapted, in my opinion, for example, that protocol is going to look like this. Take ivermectin once a week. Take vitamin D every day. Get your vitamin D levels tested, and if they are less, then this is the number of units to take. Have melatonin, have aspirin, have quercetin, have zinc. And what should happen is these prophylactic protocol packages should be available at all pharmacies. And with them, there should be a pamphlet that says what kind of comorbidities have contraindication to what parts of this. Or if you have comorbidities, if your age is such or you have comorbidities, please go to doctors. And which comorbidities? Those that are more severe, that the people who have those comorbidities have more severe effects. So go to a doctor, and there should be a doctor sitting somewhere, which should be free of cost, who should look at you and say, okay, out of this package, here are the things that you can take, and here are the things that you cannot take. So that prophylaxis and the management around the prophylaxis and making that available to people widespread, I think will take care of all the deaths that are happening. It would not allow anyone to progress towards death. So adapt that protocol and then execute that protocol. Similarly, so I have written these points over here. Similarly, adapt a protocol for somebody who actually does become sick. A protocol like President Trump's management. I don't know if remdesivir was very useful in there or not, but a protocol like that, for example, Regeneron's antibody cocktail with ivermectin, with vitamin C, with vitamin D, with zinc, quercetin. So those standard things that we talk about, these should be available at clinics and in hospitals and should be started immediately, instead of saying to the patient that, hey, go home and wait. That is criminal when we ask somebody to wait, at least now. So maybe 10 months ago, we did not know how to manage. So it was fine, we did not know what to do. And so we were just saying, ask people to go home and wait. Now we should not do that. So in my opinion, the second part of the management protocol should be this. Then a drop of more than 3% of oxygen saturation. So oximeters should be available in those packets as well. And if a drop of more than 3% is observed, ask the patient to go to hospital and then start President Trump-like treatment right away. Get them out, save them. Don't let them become a long hauler. Don't let them go through the misery of being in a hospital. Don't let them go through the misery of being on a ventilator. So that's the next. Then figure out a way for flu shots, vaccines, interaction of those. There are so many questions. People are afraid, should we take flu shot or not? Should we take a vaccine or not? So figure out a way to say who is important to have these. What are the comorbidities? What are the age factors that are important for people to have these, and recommend them? With that, again, hydroxychloroquine, ivermectin, and other. Then temperature checks should be common. I see that happens here in some shops, but temperature checks should be more often in the society, so allow the areas to be relatively healthy. Masks should be made mandatory. I know that some of you would become upset with me about masks, and there is so much disinformation about masks. Somebody was trying to argue with me, and I don't debate in these things, argue with me that the virus is going to move around with the Brownian movement. Then how are you going to say that the mask is useful? And the virus is 0.1 micrometer, and the mask has 3 micrometer holes in it, and it's going to just move through the Brownian movement into the through the mask and go into your mouth. And I have had this discussion before in a video, that the virus by itself cannot fly around. It doesn't have wings to fly. It is going to come out of my mouth on a particle. That particle can be anywhere from 5 micrometer to 10 micrometer and above. It is possible that the virus particle is greater than 5 to 10 micrometer, and the vapor, and the virus is sitting in there. And then because of the environment and the dryness of the environment and the temperature of the environment, some of the vapor is just evaporated, and the virus, the particle becomes aerosol, and it becomes 5 micrometer. Now it's going to suspend around and stay there. It is going to have Brownian movement as well. Fine, if you have heard that word, Brownian movement, that is a physics word. But still, the virus itself is not going to fly around. It is going to sit in a particle. Virus cannot fly unless you actually have virus somewhere on a surface. It is dried up. It is just a quantity of virus, and you kind of blow it out. And then it just flies from some dry surface. When it comes out of our mouth, it does not come out by itself. So now when it goes to a mask, it is going to get trapped in the mask. That particle is going to be trapped in the mask. Now, what are the possibility for that cool bean who was trying to put this comment and saying masks are useless? What is the possibility of what he said happening? That possibility is, for example, let's say I have a mask or some object on which there is virus. Then that object dries up. The virus dries up as well. And now the virus has dried up enough that it is not on any water particles anymore. And now it can kind of fly off from here because of simple movements, or because of, let's say, something blowing air. But please realize, this is a virus that is membranous. It needs fluid in it. It needs water in it. So when the virus is going to dry up, it is going to become inactivated. If it has become inactivated, it can just roam around as much as it wants. It cannot do anything because it cannot have a spike protein that would connect with us, because that spike protein has shriveled with its membrane. This is like a Coke can that you have shriveled. So masks are such an important thing, and I am so surprised that there is so much of disinformation out there about the mask and the virus moving around in the air, and the virus size is this and the mask size is this. It's just, anyway, so masks. Then identify the hot spots where the infection is spreading. Lock them down, or do smart lockdowns there. So don't just have the whole country locked down. Have smart lockdowns, figure out where the infection is spreading more, lock those areas down, then figure out what to do there and how to do prophylaxis there, how to do great management there, how to secure that population, and then lift the lockdown. Then figure out how do we have widespread availability of Regeneron's cocktail, And I have no financial or other interest with Regeneron. I do not own their stocks. I do not know these folks. I have nothing to do with them other than, can we cool beans be saved? That's all. So figure out how to have the Regeneron cocktail be produced in mass and be distributed. How do we produce vitamin D meters in mass? How do we bring at home testing kits for RT-PCR, for the virus, for vitamin D, for zinc, and for other such things that are necessary? Enable people, just like we do blood glucose levels at home and then manage ourselves. Enable people to manage themselves for COVID instead of doing contact tracking and lockdowns and sophisticated testing and the number of tests, and that all is useless. Just enable people at home or in their communities to be able to test themselves and then educate them how to protect themselves, and done. People would do it by themselves. This is a situation where people are more concerned for themselves, and they would do the right thing if we are presenting to them that here is the right thing to do. I'm sorry if I'm just speaking too much. You can ask me to stop. So make quercetin, mask, melatonin, hydroxychloroquine, and Viptadil available. Then adapt procedures for opting in various treatments. So for patients, there should be forms to say, hey, this is the side effect of these drugs. If you have comorbidities, do this. Have some sort of a helpline available, and let people start managing themselves. Make vitamin D tests available at home for free. Make RT-PCR tests or rapid tests available and free for home. And then offer protective measures for those who are more vulnerable. Give them financial aid. Give them aid to get them proper protective measures that they need. Or if they have to stay sequestered or in quarantine, give them the money to take care of themselves during the quarantine. And then the others who are relatively young, others who have less risk, allow them to come out in the societies and work while all those protocols are in place. I think if we do this, the pandemic would disappear. So good question, K-pop super strong. I hope I did not bore you guys too much with my rant, but that is what I feel. Then I'm going to come to the live in a second. Rilo Jero says, hello, doctor. Have you heard of niacin as COVID-19 treatment? I will do some research on that. Let's go to the live side. Wonder how they sleep at night. That's exactly what is happening. Doctors don't normally vary from pathway protocol because they're afraid of getting sued. That is exactly correct. So that is what I tweeted as well a few days ago. Somebody said, why are doctors not doing the right thing? And I said, because they're afraid of getting sued and the liability, and patients coming in and saying, you did not follow the protocols and procedures. You were at fault. We are going to sue you now. So they are just doing what is by the book. The problem is that the folks who are creating the books, like CDCs and FDAs, they have totally dropped the ball. They are playing with the situation to just, I don't know, incompetence, indifference, or socioeconomic benefits. Absolutely. Jordi says, should goggles be airtight or just sight protection? The point is that the virus should not reach the conjunctiva, so good goggles. So Lynn, at least in the US, getting ivermectin is a problem. Dr. Bean for president. So I'm hoping that some people wrote my name in the ballots. Absolutely. So this is Sysmac. I will always put my mask under the sun in my car when I drive, and it killed. Absolutely. Okay, so all right. So I'm gonna. Jamie says, yes, Dr. Bean, this is a simple uh, proficient in management plan, prophylaxis and management. It is simple as Dr. Zelenko got in touch with President people early on. I wish this could get to them as well and implement. I hope so. I am disappointed at our medical leadership. Biden or Trump, I think at the end of the day, the bureaucracy down below is not doing the job. So, Martin, if they have suspended Regeneron in very sick people, that is actually fine, because in very sick people, it is the immune dysregulation and Regeneron cannot do anything. It is the antibody cocktail. It is the early stages where the anti-monoclonal antibodies are useful. So this should be as soon as you have the symptoms. We don't care it is common cold. We do not care it is rhinovirus. Let us just, if you have the symptoms, let's treat you with this. Let's get you out of the situation and protect you. That should be the answer. Yeah, medical system lawyers are too involved. Absolutely. And that is what scares the doctors from trying to do things. Okay, so back here on the Twitter side for a second, Puya Dhagni Mubarki says, dear Mubin, discuss IgM positive and IgG negative with possible sudden arthritis. So I need to understand a little bit more about the context, that what is the basic situation. IgM positive is fine. IgG negative means that the class switching is not occurring. So what is happening is, if I go here, it is a B cell. So when the B cell has interleukin 4 and interleukin 5 released on it, interleukin 5 will cause the B cells to become active and proliferated and increase in numbers. And interleukin 4 will cause them to class switch from IgM towards IgG, then from IgG towards others as well. So it is possible that in some person, IL-4 is not released correctly. So the B cells are not doing class switching, but they are proliferating. And by default, every B cell makes IgM and IgD. These two are made by every B cell that becomes active. But for them to make, for the B cells to make IgG and IgE and IgA, we need them to class switch. So if the interleukin 4 is not present, then the class switching would not occur. So if there is somebody who has an immune system issue that they cannot produce interleukin 4 in enough quantities, or their B cells are not responding to interleukin 4, then they would not class switch and keep producing more IgM. Now, if they are continuing to make more IgM, there could be arthritis, because this seems like their immune system has an abnormality, and there could be an autoimmune disorder in them as well, which can, one of the symptoms could be arthritis. But again, without more context and understanding more, I'm just speculating here. K-pop super strong. What if we used ivermectin, aviptadil, proning, and corticosteroids in the beginning of the pandemic or around late May or June, and we didn't rush in intubations? So I am always very careful looking back and saying if we should have done it differently, because it kind of, those who have lost their loved ones. I have a few friends and close ones that have lost to pandemic as well. Those who have lost people, they kind of would feel even worse now, that if we come back and we say, you know what, the answer was actually very simple. So I'm always careful and sensitive for that. But this is correct, that if we had the vitamin Ds, we had the zinc, quercetin, ivermectins, steroids, timely usage, then we would have saved lots and lots of lives. I would reformat your question to this. If we implement this now, can we save lives from now on? And yes, we can. Maybe my belief is wrong. I believe that we can actually reduce deaths to zero if we start treating early instead of asking people to sit home and wait. MT says, COVID-19, as steroid use reduces immunity when virus is still present. If a patient plus pulse oxy drops to 90 in first few days of infection, Is it best to start on low dose steroid 30 milligram, 40 milligram per day, or better to immediately use a high dose? Very good question. And we have talked about this a couple of times today. When the oxygen saturation drops below 93, then there is an alarm, there is an issue, and we should start using steroids plus the anticoagulants. Now, it is important that if we can give 4 or 5 days to a patient to start developing their antibodies. But as you can see from some of the doctors here who have been talking about, he is a patient himself, but he did not develop antibodies. So the answer to your question is, don't start it on the day one, the steroids, but then look at the rapidity of deterioration. If the deterioration is too fast, then start it right away. Even if that makes the virus increase in number, we can manage that with ivermectin. But once the immune system becomes dysregulated, then the patient can very rapidly decline and is at severe risk. So then you start the steroid early on. Dr. Dharmendra says CD147 receptors as a real explanation for all inflammation. Thank you. Thyra Danny Virk says, my sister can't take steroids. Are there any effective treatments for long haulers that can't include steroids? Thyra, for me to give a specific patient's management here is not the right thing to do. So it really depends upon her history. Why can't she take steroids? What is the immune system suppression issue that would occur? And then what is the dysregulation that is present? And then what are the specific drugs, for example, Anakinra, interleukin 1 or interleukin 6 or interleukin 12 blockers or Rantis blocker? Then we can give specific blockers to try to handle that. And by the way, hydroxychloroquine is also an immune system modulator. James Kelly has 2 comments over here. One comment is, question, we cool beans whom admire you so much all read a lot of science studies. Can you please go over confidence index or interval? James, I would do it. I had done this once before, but briefly. So what I'll do is I'll do a separate topic of understanding the confidence interval, what is 95% confidence interval, and then the ranges and p-values. So I'll do it. Another comment from James Kelly. Dr. Mobeen question, Dr. Lonsdale is considered to be one of the best eminents on the topic of vitamin B1 thiamine therapy, and thousands of following have advised to take high dose thiamine by even Dr. Merrick. What are your thoughts? So I think I have my video over here, high dose thiamine and cytokine storm. So high dose thiamine actually modulates the cytokine storm and helps it. It is part of the Math Plus protocol as well, and I believe in that as well very strongly. So the last one over here, Ha Min Bean. I just noticed Dr. Z's dosage of zinc is much higher than the protocol discussing in the Beanery, wondering how much of the lifting is zinc doing relative to the ACQ. So there is a lot of discussion in the community to say that zinc does the heavy lifting and ACQ only allows it to go in. HCQ does a lot of work as well. So they both are a good partner, but ACQ has its own function and zinc has its own function. Dr. Merrick's comment caused me concern as to when exactly to use budesonide. So that is the same discussion about steroids. Steroid early use can suppress the immune system and cause the virus numbers to increase. However, it really depends upon a person's clinical situation and how rapidly they're declining, that should we stop the train from becoming runaway. If you as a doctor are seeing that the clinical deterioration is too fast, then give steroids and stop it. And then we have to fight with the virus by antivirals and things like ivermectin. So that is how to look at it. All right, so that is the Twitter site. Let me look at some of the comments here, and then I know it is 7:40. We'll stop as well. 1x2 says doctors are still saying D at 20 nanogram is sufficient. The study that I did, 1x2, that said 40 nanogram and above. I have been taking 20,000 international units daily to bring it at 44. And so I believe that 40 nanogram and above is better. So Barbara says, yes, we can actually reduce deaths to virtually zero if we do exactly that. Treat people early in the phase-specific manner and stop telling us to go home and live or die. Absolutely, you're correct. So Greg McClellan has a question. What about the possible problems with having ankylosing spondylitis and interleukins? So Greg, tweet at me. I need a little bit more history before we can talk about it. So Iqbal Khan says IgA nasal drops will provide prophylaxis against SARS-CoV-2. So many conditions here. IgA in the mucosa is definitely protective. Questions are the following. If you take a nasal drop for IgA, how long an effective quantity of IgA would stick around? Remember, when our nose becomes congested, we very rapidly clear it. So the fluids are not going to sit there for long, number one. Number two, do we already have the virus from, let's say, oral route? Or will the virus come in through the oral route? Then what is the right quantity of IgA to be put in here? So I think it's a weak control. Just like gargling cannot create a protection forever. As soon as you gargle and finish, then the virus is going to start increasing again, or we are going to start becoming exposed to the virus again. But if you continue to do gargle after every few, let's say, hours, then even when the virus has arrived in our body, we still have a way to kind of kill it and continue to keep ourselves at a low viral load. So acoustic theory says, can IL-4 be administered? Yes, yes. Straightline says, tape and ivermectin dose to your Windows computer, no more virus. Absolutely, even on the Mac computer as well. But Mac doesn't get those viruses. Yes, Windows computers need more of them. Cool. So I think this is the basic discussion for today. My request to everyone, please like, subscribe, share. And then if you wanted to support my work, there is a link in the description for that. There is one last question and then we stop. Anthony says, have you seen study on galectin inhibitors? Believe expanded study happening in India. Theory is spike protein resembles human proteins. So taking anti-galectins meds will be. So I have talked about galectins, and I have a friend who is actually very closely related to galectin manufacturing. I have Anthony, I've done a video. It is called lectins. So please look at that. And yes, galectins seem to be a very important possibility as well. Cool. So this is it for today. Thank you very much. We will continue our discussion tomorrow. So please, once again, like, subscribe, and share. And I would see you tomorrow. Stay safe and happy. Bye-bye.